second speaker is Dr. Matthew Klein. He is Associate Director, actually, of our University of Washington Burn Center. He is the Program Director for the Division of Plastic Surgery and an Associate Professor in that division. I see him often at Harborview, where he's currently attending. He was given an endowed chair by the David and Nancy Oth Washington Research Foundation, and this is an endowed chair in burn surgery. For his academic pedigree, he started off at Yale, then moved to Stanford for his residency, and he actually did both general surgery and a plastic surgery residency. Then he moved up to Seattle, and thankfully he didn't move away either. He came up here to do a burn fellowship. For his clinical practice, obviously, it focuses on burn care, both acute care of these patients, which is very complicated, and reconstruction, which he'll show you some photographs. I know about his research program in that I had the pleasure of working with him. We co-taught a summer course for physicians that are interested in doing research. He is a phenomenal investigator. He has an adjunct appointment in the School of Public Health in epidemiology and is a very prolific scientist and asks amazingly important clinical questions. At this point, I'd like to turn things over to Dr. Klein. Thank you.
Thank you. Thank you very much, Dr. Elmore. I'm going to be continuing with this evening's theme of looking at things that are more than skin deep. And I want to start with the question about what is plastic surgery. And I think, unfortunately, for the public, this is our notion of plastic surgery, either Doc 90210 or nip tuck. And often when people ask me what I do and I say I'm a plastic surgeon, they say, oh, just like on nip tuck. And I said, well, actually quite far from it. And while plastic surgeons are cosmetic surgeons in some cases, we're also breast surgeons, reconstructive surgeons, craniofacial surgeons, hand surgeons, microsurgeons, and in my case, and some of my colleagues, burn surgeons. And so as plastic surgeons, what we do is develop creative approaches to difficult problems everywhere in the body. We operate on people of every age. In a given month, I may operate on a newborn, 1 week old, and operate on someone who's 90 years old. And we also operate on every anatomic area from head to toe. We truly go through the skin, go more than skin deep, and deal with all the contents below, including muscle, fat, tendons, bone, nerves, arteries, and veins. And I'm going to be showing you some of these as we move along this evening. So I refer to our work over at Harborview as really Docs 98104, where we work on reconstruction of traumatic defects, such as those that could result from a burn injury, motor vehicle collision, or severe infections, and also other acquired defects, such as those that result from cancer or even some congenital anomalies. Plastic surgery, if nothing else, is a practice of principles. We need to examine a problem, make a diagnosis, determine what tissue is missing, and then we try to identify options for tissue replacement or reconstruction, all with an ultimate goal of restoring a patient's function and appearance. What guides us in our reconstructive planning is what we call the Reconstructive Ladder, which is an algorithm for wound closure that starts with the technically easiest method of solving a problem or closing a wound, and it becomes progressively more difficult as we move up the ladder. And this is a very basic diagram showing what the reconstructive ladder is, starting with secondary intention, moving up to direct closure, skin grafts, local flaps, distant flaps, and free flaps. And I'll go over each of these in a little bit more detail. First is secondary intention. And that's just simply allowing a wound to heal on its own without necessarily any surgical procedures. This is a patient, this is a thigh, this is the other thigh, and this is the perineal area near the genitals that had an infection, and the infection was treated surgically by Dr. Foy and his colleagues, and the patient was then referred over to our plastic surgery service for wound closure. Without a lot of imagination, you could sort of see that this wound, left to its own devices, will sort of just close right up on its own, and really no surgical procedures were necessary, rather just a couple of weeks of wound care. And this healing by secondary intention is the bottom rung of the reconstructive ladder, and it has its role. Obviously not in every case, but there are certain cases where it's far better to allow things to heal in than resort to a different surgical procedure. Next is primary closure, what we basically refer to as stitching something together. Someone has a cut on their arm or face, as most of us have probably had sometime in our life. We go into the emergency room and things are treated with primary closure, just suturing the wound closed. In order to do this, you need enough laxity in the tissue in order to bring it together. And this is a young girl who I treated who had a scald burn when she was 2 years old. Here she is at age 6 with a large scar on her chest. We took her to the operating room and just cut that scar out, had enough looseness in the tissue around, and stitched it shut in a nice layered closure, as you see here. And that healed up very well without now having this lumpy, bumpy scar, which was a source of both disfigurement and significant discomfort for her. Next rung on the ladder is skin grafts, and this is something we use quite often in the management of burn injuries. A skin graft is simply a portion of the thickness of your skin. The skin has 2 layers, the epidermis, which is the outer layer, the dermis, which is the inner layer. And when we take a skin graft, we take the whole outer layer, a little bit of that dermal inner layer, and where we take the skin from, the donor site heals up, and then we move the skin graft to the area which would not heal unless we placed it there. This is a patient who had a grease burn to the hand, as you see here. This patient was taken to the operating room, the burn removed, and a piece of skin was taken from the thigh and placed on the hand, and that healed up very well. It's important to know, though, if you're going to use a skin graft to close a wound, that certain things need to be in place. That is, there needs to be enough blood supply and nutrients in the place where you put the skin graft so that it can heal in an effective manner. And skin grafts, in general, will not take over bones and tendons, which is what brings us up to the next rung on the reconstructive ladder, which is a flap. A flap refers to tissue that's transferred from one place to another with its own blood supply. Flaps can be of skin alone, skin and muscle, muscle alone, skin, muscle, and bone, or any other combination thereof. And it can come from somewhere in the same location as a wound or from far away. This is a patient that we took care of at the Veterans Hospital that has a pressure sore. This is a person who has quadriplegia, is paralyzed from the neck down, and unfortunately we see pressure sores in these patients quite often. And actually, if you probe this wound, it goes right down to the bone, so there's no way that you can stitch that shut without it coming apart, or put a skin graft there because it's on the bone. This patient needs nice, durable, soft tissue coverage because this is an area on which he's going to be lying for the remainder of his life. So it's closed with what we call a rotation flap that's taken from the side here and then rotated in to fill in the hole that's there and provide some adequate padding over that area. The ultimate in flaps, or the ultimate in a flap taken from far away, is something called a free flap. And as you recall, this was that highest rung on the reconstructive ladder. A free flap is a piece of tissue that's taken from a remote area of the body. It comes with its own artery and vein that then needs to be hooked up to an artery and vein where the flap is put. This is a patient who had an injury to the back of their hand, automobile accident, hand dragged on the ground, bone fractured. You can see a titanium plate here on the metacarpal bone in the hand. You can see the extensor tendons there exposed. Now, there's no way you're going to sew that wound shut. I mentioned already that a skin graft's not going to take over tendon and bone, or titanium for that matter. There were not a lot of good local flap options, and this is tissue that's taken from the patient's thigh, and you see here the artery and vein that provides blood supply to that fascia. It's a large piece of fascia taken from the thigh, brought up to the hand. These vessels are sewn into the radial artery and vein which are in the wrist, and we're able to cover up those tendons, the plate, and the bone, and then put a skin graft on that. So what I'd like to do with the remainder of this talk is to sort of take you on a tour from head to toe of some of the patients for whom we care and explain how we approached managing their wounds, how we closed their defects, how we took this principled approach of analyzing a problem, carried along with us our reconstructive ladder, and then figured out what the best solution was for each patient. I'd like to start with the head and facial burns, which is something which is a large part of my practice over at Harborview, both taking care of acute facial burns that require surgery and reconstruction of facial burns. And facial burns really pose challenging acute and reconstructive problems. I think more than any of the other wounds we treat, the aesthetic and functional outcomes of facial burns are critical to a person's daily existence because facial appearance is so integral to an individual's feelings of self-esteem. The way we manage facial burns, particularly surgically, is that we try to determine what the healing capacity of the wound is. If a patient has a facial burn that is unlikely to heal in 3 weeks' time, it's become quite clear over time to us that these patients would benefit from having the burn surgically removed and then a skin graft put in its place. The reason for this is that prolonged healing times are associated with significant scarring. And if we're trying to provide the ultimate outcome in terms of form and function, then minimizing scarring is obviously very important. When we do a facial burn surgery, these procedures require both a methodical approach and attention to detail, as I assume is quite obvious. This is an example of a patient we cared for last year. He was a 43-year-old gentleman who had burns to 43% of his body. He had had many of the other burns on his body treated, and he's left now with these very deep, now red and raw burns. All the burn tissue has fallen off, and he's left with a raw wound that needs to be grafted. The patient was taken to the operating room, and this is what it looks like when we excise a burn. So you can see here it's down to the level of the fat on the face. And when we excise burns and graft burns on the face, particularly in men, it's very important that we take away all the tissue that has any hair follicles in it. And that means that we have to go down into the fat, because if you put a skin graft on top of hair follicles, the hair and the secretions from those hair follicles will actually dislodge the graft. They'll get infected and we'll lose the graft. So this is a deep excision down through the layer of the hair follicles on the cheek. And here's the opposite side of his face. His burn also extended down to his neck. To cover this, we actually used an artificial skin substitute, which we use quite often in caring for major burns at Harborview. This is a replacement that has a permanent component to it and a temporary component. We put it on the wound bed. The permanent component has blood vessels grow into it, and then the outer layer here, which you see is this shiny silastic layer. Once this product is adequately vascularized, we take off that silastic layer and a piece of the patient's own skin is placed on. So this obviously, when we talk about our reconstructive ladder, this is skin grafting, and that's really the standard of care for taking care of deep burns, particularly of the face. This is the patient's results at 7 months' time, and this again comes from just taking very meticulous care and attention to detail so that we line up the skin grafts. As you can see here, the border of the two grafts on the neck and the face line up right at the border of the jaw, which is really important because when people's burns and skin grafts heal, one of the things we're very wary of is things that would stand out. And if you put this juncture on the side of the cheek, when someone walks down the street and you see a scar here along the side of the cheek, it's a lot more conspicuous than I think if you saw this gentleman, and really that line, that scar where the grafts come together is in a natural place where on each of us, we have a line that marks the separation between our cheek and our neck. This is a gentleman who had a slightly more complicated burn to his head. This gentleman came to us in the summer, and he had retired and was volunteering building churches, and while he was up on the roof of a church he was building, his head hit into a high tension wire that had 14,400 volts in it that went right to the back of his head here. As you could tell, this is probably quite deep and goes more than skin deep, as we've been talking about. And just a side note about electrical injuries, they're one of the most complicated burn wounds we can take care of. They usually involve the skin and the deeper tissue, and a patient can get any number of injuries. One is an injury alone from the current that could actually affect the heart, and occasionally we have folks who have high voltage electrical injuries whose heart will stop just because of the jolt of electricity that goes through their body. And then there's also can be a burn from a flash that may occur from an electrical injury. Clothes can catch on fire and a patient could have a flame injury. And there's also the possibility of other associated trauma, because you can imagine if you're a lineman working in a cherry picker and you hit a high voltage line and you get a shock, you could easily fall out of that cherry picker, and now you have a shock from the current, potentially a flame burn, and now potentially other trauma because you've fallen a great distance from a cherry picker. And not surprisingly, these combination of complicated injuries can have a number of both acute and chronic manifestations. Well, let's get back to our patient. We took him to the operating room, took this black dead tissue off, and we're looking here at skull. It actually turns out that once we were done getting rid of all the burn and after some dressing changes, that portion of the skull itself had died, and we had to go ahead and burrow away and remove a part of that bone so we could get down to healthy appearing bone. Now, I think it's quite clear there's no way we're going to stitch the two ends of these wounds together. And I mentioned to you already that a skin graft is not going to take on bone, so we've exhausted that rung of the reconstructive ladder. And so now we're talking about something more complicated, getting tissue from somewhere else and bringing it in. And ideally for this large area, we'd like to have something that would be able to protect the bone underneath, and muscle would be a good choice. We used a muscle in the back called the trapezius muscle. I think most of us know about this. It's the one we use when we do pull-ups and such, and it's located right here. And we were able to take this man's trapezius muscle and then swing it up here and cover that bone that was exposed. It turns out that we weren't able to get the entirety of the bone covered, and what we were able to do is lift up the patient's scalp and actually slide it back a little bit. So he had a combination of two flaps, one the muscle from his back, and then a portion of his scalp that we were able to lift up and slide back a little bit and achieve complete closure of the wound. And here he is 4 weeks later as he finished his stint at our rehabilitation unit, ready to go back home to Texas where he lived. So the steps here were removal of all the dead skin and bone, come up with a plan to cover what his needs were, and the coverage here consisted of bone coverage with the regional muscle, the trapezius, and then a local flap of scalp, and then a skin graft on top. Moving down the body to the hands, this is another patient who had a high voltage electrical injury. This was a 19-year-old man who was working in alignment in Alaska, and he also came into contact with a high voltage wire and had this deep burn to his hand. You can see here, this is burned through skin and some of the tissue below it. His index finger, as you see here, is actually pretty badly burned, and we were actually not able to save that. It was non-viable. The bone and this tissue above it was dead from about the first knuckle all the way out to the end of the finger. And once we finished taking away all of his burn and amputating the finger, we were left with a pretty complicated wound. He's got some tendon here which is exposed, and he's got some tendon here which is also exposed. And actually, it's hard to see here very well, but there's some bone exposed there. So again, let's not even talk about closing this primarily. There's no two edges to bring together. With tendon and bone exposed, it's a pretty hard thing to imagine we're going to skin graft this with very much success. So again, we needed to come up with some tissue that was ideally in the neighborhood that we could bring in that would provide the blood supply in which a skin graft could live. And we did something called the radial forearm flap, and this is a scheme showing the anatomy of that flap. This is the radial forearm. This is the forearm, rather. Here's the radial artery and vein. We all can, when we kind of feel our pulse going rapidly, we're feeling our radial artery right here. And it provides blood supply to a whole lot of tissue on the forearm that we're able to use in reconstructing defects of the hand. What we did here is we opened up the skin on the patient's forearm and took the fascia, again, that thin layer of tissue that overlies the muscle, raised it up from the entire forearm, and this is what it looks like here. This pointer is pointing to the radial artery and the radial vein. It comes up through here and provides blood supply to this entire piece of tissue. We then took that tissue, wrapped it around the thumb that had the exposed tendon, and also wrapped it in that hole which existed where we took the index finger from, and provided a nice vascularized base of tissue on which we were then able to place a skin graft. This is what the flap looked like when it was all inset, wrapped up nicely around the thumb and the hand. And here's a piece of skin that was taken from the patient's thigh to cover up all of those areas, as well as the more superficial burns on the third and fourth digit. Here's the patient a year later. He just actually came back to see me last month, and he has obviously a very nice functional result. And we're actually going to plan on doing a little revision surgery here to deepen this crevice here to give him a kind of deeper web space to grab things easier. But he's quite happy, and we were able to get this all covered, and he has excellent function with that hand. This is a patient who had a burn injury actually at 4 weeks of age. She came to our burn center. She was dropped accidentally into a space heater and burned her hand and forearm quite badly. We treated her at that time with skin grafting, and actually we lost her to follow-up. She and her mother moved around the country actually quite frequently. And she came back to our, this is very interesting, she came back to us because her mother was involved in a lawsuit, and they wanted an expert medical opinion on the child's damages. And when we saw her hand 4 years later, actually 5 years later, this is what it looked like. This is her palm, and her fingers are going backwards because she had a skin graft here and developed such horrible scarring that the scar pulled down so much that her fingers and her wrist just pulled all the way backwards. It's quite clear this is not going to be a very functional hand for her, and in fact it wasn't. It just kind of sat there while her other hand, her left hand, did most of the things that she did as a small child. So this is actually a complicated problem. What we have to do is we have to release the scar, because there's scar not only of the skin, but of the tendons underneath, the tendons that move the fingers. the fingers themselves have been pushed back so long that the joints are not used to functioning in this kind of direction, but have gotten scarred up going backwards and not being used. So all of these things, the skin, the tendon, the joints, need to be addressed to restore function. So we took the patient to the operating room, took away the scar, dissected down the tendons, dissected all the scar off the tendon, then went to the joints and took all the scar off all of her joints. We were then able to move her fingers forward. I don't have any pictures of it here, but we put wires in each of the joints because the fingers were so used to being that way that we wanted to erase that memory by fixing them in the position, a more functional position downward, and we did that using temporary wires that we took out. And here she is 3 months later. This is the skin graft that we use in the back of the hand because there was tissue there that we were able to skin graft. And you see now that her fingers have been brought forward into a position of function. So remember, her fingers were going backwards now. Her palms down here, this is the back of her hand, and everything is oriented correctly, and she's functioning quite well. This is another patient who had a deep hand burn. This was from a flame burn. He was 32 years old and fell asleep in the back of his horse trailer, and there was an explosion, and he caught fire. He had deep burns to both his hand and his face. We treated his face in a manner similar to the first patient I showed you. But he had this hand burn, which is horribly deep. This black here is basically charred bone, and he has that on all 5 fingers. And so once we took away all the burn, as you can see, we have bone exposed here. The joints were destroyed. You can get a close-up view here of the joints, and the tendons, which are the extensions of our muscles that control the joints, were burned away. And so our challenges here were to not only get the wound closed, which we've already talked about is not going to happen with the skin graft alone because we have all this bone exposure, but we also had to figure out a way to stabilize the joints because the stabilizing forces, the tendons and ligaments, were all destroyed. So we ended up actually amputating his small digit because we didn't think there was any way we could fix it. And we put wires in his joints here to basically fuse his joints. And by fusion, we mean we bring the bones together so that the joint won't move anymore, but at least it'll be stable and fixed in a position of function. If we left his hand like this is not very functional, but if you can put your joints in a position such as this, you can imagine with your other hand functioning, this becomes a very useful, functional helper hand. And since his tendons were destroyed, there was no way on his own he was going to get motion back there. So we made the decision early on to fix his joints in a position that would be functional for him over time. And that brought us to our next challenge of trying to get coverage over this hand. Well, we couldn't skin graft him because the bone was exposed. There were no local flap options like the forearm flap we use on the other patient because his forearm had been burned so badly. And so then we were left thinking about moving tissue from far away. And this is kind of an old plastic surgery technique of taking one part of the body, and in particular in this case the hand, and burying it in the belly. And that's exactly what we did. So we went down to his belly, drew out 2 separate flaps of tissue, one here for his hand and one here for his thumb, and inset his hand underneath there. Over the course of 3 weeks, blood supply from the flap, from the belly, would grow down into the hand such that we could take his hand out 3 weeks later with a layer of tissue from the belly on top that would have its own blood supplied to it, and then be able to put a skin graft on top of that. And then just put the remainder of the components of the belly. So in this case, we took a layer of fascia from the belly with his hand when we took it out, and then just laid the skin right down, sewed that back shut, so that just had a scar around his belly. And then we were able to put a thin skin graft over his hand. And here he is a year later. His graft's nicely healed with very nice, that nice function that we aimed for, which has worked very well for him, and he's back at work as well. When we talk about the outcome of how our patients do, the ability to return to work is probably, and for kids return to school, is probably one of the most significant outcomes. Because if you think about what you need to do to go to work or to school, if you're of school age, it's the ability to achieve a certain level of function, an emotional preparedness, an emotional and psychological ability to go to work and participate and communicate with other people. So the ability to return to work is a very good catch-all for someone doing very well in terms of how they feel and how they function after a severe injury. The last hand case I want to show you, this was a patient who was sent to me by one of our dermatologists. He's a 50-year-old man who had a kidney and pancreas transplant and has been on lifelong immunosuppression. And one of the side effects of lifelong immunosuppression, the anti-rejection drugs, is the development of invasive skin cancers. And he had all over his hand squamous cell carcinomas, many of which had been removed before, but he kept having recurrence and recurrence and recurrence. And my dermatologist colleague sent him over and said, is there any way you could just remove his skin and give him new skin on his hand? And I said, okay, we could do that. But one of the challenges is someone who's on immunosuppressive medications so that they don't reject their organs, one of the effects of that medication is also it prevents you from healing very well. And so to go and take skin from another part of his body and move it onto his hand, it would be tricky in terms of getting things to heal on the hand, and we'd create a whole other big wound somewhere else that we may have trouble healing. Well, we went ahead and took him to the operating room and took off, this is all the skin on the back of his hand where there was abnormal tissue that looked like it was either cancerous or precancerous. And we went ahead and covered him with cadaver skin. Now, we use cadaver skin quite often in the management of large wounds as sort of a temporary cover. It's skin that's donated just as other organs are. It's stored in a skin bank, and when we need it, we're able to obtain it. And in fact, back in the 1970s, people looked at using cadaver skin long-term as a skin transplant for burn patients who had such severe burns, such as 60, 70, 80% of their body, that they may not have had enough of their own skin to cover. Well, the problems there were twofold. One was that there was a fear of giving someone lifelong immunosuppression for just the skin as they saw it back then, and didn't think the risks were worth it, considering we had some other approaches that we might be able to take in order to get skin wound closure. And the other was the availability of cadaver allograft skin. It's actually not readily available in many places. And for those reasons, that technique or that approach to skin replacement went away. But it turns out two things. One is that I mentioned it before, the skin's a bit of a complicated organ. It has two components, the epidermis or outer layer, the dermis, the inner layer. And it turns out that most of the immune cells in the skin, and there are a lot of them, in fact, the skin is your largest immune organ in the body, are located principally in the epidermis, so that the dermis alone does not have much of those immune properties. You're less likely to reject dermis per se. And I also figured, well, here's a gentleman who I don't want to take a big, thick skin graft on because I'm worried about his healing capacity of his donor site. I know dermis itself doesn't have many immune cells. And anyway, he's on immunosuppression. So that may have given us a little window. So we went ahead, took him to the operating room, took the skin off the back of his hand, put the cadaver skin down, waited 2 weeks for that cadaver skin to take, took the outer layer, that epidermis where all the immune cells are located, off, and then took a very, very, very thin layer of his own skin, really just the epidermis and a tiny bit of dermis, and put that on the cadaver dermis, because I knew that a very thin skin graft donor site where we took it from is likely to heal up very easily, even someone who's on immunosuppression. And this is what his skin graft here healed like, and here he is a year later. And we actually went ahead and did the same procedure on his other hand. So that was a little bit of creativity for a challenging problem. I'd like to move off the hands and talk a little bit about the rest of the body and show you an example of a patient we treated recently at Harborview who developed a severe infection in his throat that spread down actually into his chest behind his rib cage. And in order to drain the infection appropriately, our chest surgeons had to go ahead and open up the patient's chest, clean out the infection, and actually remove portions of the sternum, of the breastbone. And they then went ahead and repaired that by placing plates over the breastbone and called us in and said, can you help us cover this? And this is what he looked like once the chest was all debrided. Here he is with this hardware over the breastbone. And this is something that we can't just easily pull the chest together really, really tight and hope it stays closed, or put a skin graft over, because this is, again, titanium plates, and titanium is not going to be able to provide the necessary nutrients for a skin graft to survive. So we went ahead again and wanted to think about what muscle we could use in the area to get a nice layer of vascularized coverage over the breastbone. And we went ahead and used his pectoralis muscle. This is the pectoralis major muscle. We actually used one from each side. We were able to lift it up off of the chest wall, slide the muscle together in the middle, and then free up enough of his own skin and slide that over. And we were then able to close that wound right there in the midline. There's a little part of the skin there that didn't do perfectly. This is a recent photo because we just operated on him last month and just got these photos here, but it really is a good example of one of our what we call workhorse flaps. One of the one of the muscles in the body that we rely on for the closure of chest defects is the pectoralis muscle, and this is a good example of how we use it to solve complicated problems of the sternum that we could see following infection, or sometimes after someone has cardiac bypass surgery and they develop an infection or complication and the wound in the chest, in the breastbone does not heal very well, and then we're asked to come in and help provide coverage in that area, and we usually rely on the pectoralis muscle because it's a hardy muscle, easy to identify in the neighborhood of the wound, easy to mobilize, and then easy to close. Moving down the body to the perineal area, this is a complicated wound. This is on a 50-year-old woman who had a history of HIV and rectal cancer. She underwent a cancer operation that's referred to an APR, or abdominal perineal resection, that removed her anus, her rectum, and what she was then left with was this wound here. It actually turned out that the tumor was also invading into a portion of her vagina, so that she had an opening in her vagina as well. So this area right here is where her anus and rectum would be, and what's there now is actually a hole that goes inside her body into her abdominal cavity. And then this is a portion of her vagina here, just above where the tumor was taken out, that also needed to be addressed. She had had previous radiation in this area, and what radiation does is it makes the tissue really inflamed and really hard to kind of mobilize and close up. So just, you look at this wound in your head, you quickly run through the ladder and say, okay, we're not going to close this primarily. We can't just put a skin graft here because somehow we have to get good stable coverage, and also we have the problem that there's now a hole going from her belly to the outside world. And somehow we got to fill that hole in or her intestines are going to fall through, and that would be a big problem. And a skin graft is not going to really solve that problem very well. Well, one of our workhorse flaps for this region of the body is the rectus muscle. And by actually taking the rectus abdominis muscle, we're able to lift it up, take some of the skin on top of it, and actually pass it through the inside of the belly and then bring it out the bottom of a person. So remember I said that there's now this tunnel that connects the abdominal cavity with the outside world. Well, we're going to use that to our advantage and fill the hole in the process. Lift the muscle up with some skin, pass it through the abdominal cavity, through the pelvis, and bring it out the bottom. And what this allowed us to do, this is the skin that's on top of the abdomen. It came down and now provided a nice skin paddle to close the wound on the outside. The muscle's going through from the inside to the out, so it's plugging that hole, that new communication that existed where the rectum was taken out. And then we were also able to swing some of that skin and muscle up and reline the outside of the vagina. So we were also able to close up that hole at the same time that existed there. And the rectus muscle is really a very, very useful tool when we deal with complicated wounds in this area of the perineum. It's also the muscle that you hear people, when people get what's called a tram flap for breast reconstruction, that's also using the rectus muscle and some skin on top. Instead of going inside the belly and out the bottom, it's obviously going up and able to be shaped to reform a breast. Moving further yet towards the toe, this is a gentleman with a very deep knee burn, 25-year-old, involved in a motor vehicle collision. The car caught fire, and he had these deep burns to his leg, as well as to actually a total of 40% of his body. These types of burns here look kind of more shallow. They're third degree, but we're able to remove them and do skin grafting. The problem he had was right here, which is the top of his kneecap, which was burned, and this is essentially dead bone or dead kneecap, and we know already that very well that we're not going to be able to put a skin graft on that. So again, we're in this situation where we're going to have to find some tissue in the area to try to cover up that dead bone. Well, one of the muscles we like to use to do that is the gastrocnemius muscle, which is one of our calf muscles. We actually have two of them, one that's on the medial side and one that's on the lateral side, and this is an excellent source of coverage of the knee or anything really on the first third of your leg going from the knee down. Here's that dead bone that we debrided the outer layer of. Here's the muscle coming from the back. We swing it around, and it very nicely just lays right on top of that area of dead bone, and then we're able to go ahead and place a skin graft over it. Moving down to the feet, this is a gentleman who had, a 20-year-old gentleman who was in a motorcycle collision, fell from the motorcycle, got trapped underneath the tailpipe, which kind of centered right here over his ankle. And this is a very deep burn because, one, the tailpipe's very hot. Two, he was trapped under it. And we know that a depth of burn is usually related to the heat of the inciting agent, the duration of exposure or contact, and also some local host factors. So areas where there's thinner skin, it's obviously going to burn deeper than an area where you have thick skin. So the fact that he was trapped under a hot tailpipe for a long period of time tells us pretty quickly that that burn is going to be very deep. And we can all feel around our own ankles, and you can feel there's not a lot of fat there. You're going to get down to bone, heel bone, and ankle bone very, very quickly. And indeed, that was the case. We took away the whole burn. Here are some of the tendons here from his leg, and actually this was some bone that we debrided away. And so what we wanted to do here was come up with a coverage scheme that would, one, cover the wound, and we were concerned because of the bone and tendon we wouldn't be able to use a skin graft, and also provide some padding, because this is an area where we weight bear, we walk, where our shoes slip on and off, and if there's not something good and sturdy there, that's going to be a source of chronic breakdown over this person's life. Well, when you think about the foot, we said skin graft's not an option. There's not a lot of local muscle in the area that we're able to bring down, so this is an example where we used a free flap. Remember I said the free flap is sort of the highest rung on our reconstructive ladder, where we'll take tissue from another part of the body with its own blood supply, bring it down, and plug its blood supply with some blood supply and blood vessels where we're putting the flap. And requires microsurgery. That's the microscope, because the vessels are so small so that we could actually see both vessels and neatly place sutures in so that we ensure that there'll be good blood flow from the host vessels into the recipient flap. And he had a gracilis muscle flap. The gracilis muscle is in our inner thigh, and that's actually a nice muscle to use because it's kind of thin and it fits well on the foot, because that's an area where we don't want a lot of bulk. And also the donor site's not very conspicuous. We stitch it up on the middle side of the leg, and there's really not a lot of visible defect from taking away that muscle. It also has its own blood supply. It has a blood vessel called the medial circumflex artery and vein, which we brought down in his case and hooked those vessels into two of the vessels, actually one artery and one vein, that bring blood supply to the foot. And then put a skin graft over it, and you can see this is how he looked at 6 weeks' time, and this is very nice contour over the ankle. That's the muscle that's been transplanted from his thigh, hooked up the blood vessels under the microscope, and covered it with a skin graft. As promised, we're going to go from head to toe here, and this is the final case I'm going to show you, which is a 13-year-old boy we took care of last year who had a crush injury and a burn injury following an ATV accident. And if we've learned many things over the years at Harborview, but one lesson, unfortunately, we keep seeing time and time again is that kids and ATVs do not mix very well. And this is yet another example. This boy had a deep burn to his foot, as you see here, and then had a crush and an avulsion, a loss, basically a pulling away of the skin over the bones of his toe. And so this is also a complex wound. You look at this and you say, okay, burn wound, we could just take away the burn and skin graft it. But what on earth do you do with this? And there's also some deeper area of tendon exposed here. Well, we thought about this and said, well, even if we put a flap or something complicated over those toe bones, they're probably not going to work very well, because the ligaments that stabilize them are gone, and the tendons that would motor them are gone. And it turns out actually that if you didn't have your big toe, it may look a little funny, but in terms of function and balance and activity, you're actually going to be just fine. And so what we went ahead and did something what we kind of call Sparepart Surgery, which is when we take away one part of the body because for one reason we try to salvage some of it and use it somewhere else. And so we took the bones of his toe out and basically essentially filleted them off, and then took the toe skin on the bottom part of his foot, from the sole of his foot, and flipped that over as a flap to cover up the rest of the bone that was exposed in the foot. Because while we take away the toe, that may not have a lot of functional problems. If we took away the ball of the foot or the metatarsal bone in that foot, that would cause a lot of functional problems. So while we dealt with the toe bones, we still needed a flap to cover the metatarsal bone, and so we used what was left after we took out the bones and just really flipped that toe skin over, got nice coverage over the bone, and then just skin grafted the rest of the foot. So that was sort of a combination of amputation, spare parts, local flap, and skin graft. So just to conclude, I think we've shown you that plastic surgeons are problem solvers for challenging situations all over the body that are often more than just skin deep. And we're certainly more than what you see on Nip Tuck and 90210. We try to take a systematic approach to defining reconstructive needs and options, and it's that systematic approach that really guides our surgical decision making. And we do all this with the ultimate goal of restoring form and function. Thank you. Questions? Yes.
When you're doing these movements of skin and tissue from one area of the body to the other, well, in burns in general, I have heard that pain is a continual issue for patients afterwards. But I'm curious, when you do these transplants, is there issues with the nerves in the tissues? I know you're moving the vascular aspects of them, but can you reconnect nerves and things like that as well?
We can, and sometimes we do it intentionally, particularly if we move a muscle that we want to have function. For example, there is something called Mobius syndrome, which is a disease that kids can be born with where they don't have a facial nerve, so this whole side of their face is paralyzed. In those cases, we take actually the gracilis muscle that we put down to the kid's foot, we take the nerve that motors that and plug it into actually the facial nerve on the other side if it's working. And that's an instance where absolutely we want to take the nerve because we want that muscle to function. Similarly, if we do a functional transplant to the arm and say someone who's lost the biceps muscle, which flexes your elbow, we can often take the back muscle, move it over, and sometimes hook up the nerve as well so that you could fire that muscle so it works. In terms of sensation, sometimes we'll take the nerve. Usually we don't. And it's a little harder sometimes to take a sensory nerve and then to find a recipient nerve, particularly in these areas that have had such extensive damage that there's probably no good recipient nerve in the neighborhood.
Just a quick follow-up on that. When you do that transplant, do they have a sensation oddly placed?
Well, you're only going to have the sensation if you take the sensory nerves with you and hook them together. And again, sometimes we do that, but more often that's not possible to do.
When you make a free flap, the epidermis actually faces in at the site of the transplantation, right? So what happens eventually to the epidermis at that site? Does it get reabsorbed or does it just stay there?
Actually, that does not occur.
Oh,
The free flaps I showed you were muscle alone. So we just took the muscle alone and then put a skin graft on top. One of the benefits of a free flap is that with some planning, you can orient it whichever way you want. And part of what goes into making those operations successful is actually the planning phase and figuring out, do you take it from the right side of the body to the left side of the body, depending on how you want the vessels to lie and line up with the vessels you're going to plug them into. Where do you want the skin to line up? Do you want to take skin? Do you want to, or in some cases like in the foot, if we took the muscle and all the tissue above it, including the skin, we would have had a big, bulky flap. And really, you saw the picture I showed you on the foot, what you really want is something to have a nice contour that would not be much bigger than what ordinarily would have been there. And that's why we take muscle alone in those cases and put the skin graft on top.
Okay, thank you.
Hi. I was wondering, when you actually move those muscles, like when you do the flaps, when you move the trapezius muscle over the neck to cover it up and stuff, do the muscles where you remove the muscle tissue from, do they lose any function? Like the trapezius lose function?
That's an excellent question. Because in each of these things that we do, it's a little bit of robbing Peter to pay Paul, if you will. Skin graft is a very simple example where you're obviously going to take a piece of skin from somewhere and leave a little bit of a defect and move it someplace else where you really need it. In many of these cases, the muscle that you move may not have any functional deficit, and that's a consideration to make. For example, the gracilis muscle, when you take it away, part of its responsibility is moving the thigh. Well, there's so much duplication of muscle activity in that area that you really don't have a functional deficit. Similar to the trapezius, we move that muscle there, we'll no longer have the function it had before because we've disrupted a lot of the connections that would bring forth the function that it had before. But there's enough duplication in that area that the other muscles can pick up the slack, if you will, and not leave someone with a functional deficit. Last question?
Do you use leeches or maggots?
I'm sorry?
Do you use leeches or maggots for healing?
Lasers or magnets for? Leeches
or maggots.
Leeches or maggots. I've never used maggots. Leeches are something that people use to help rescue a flap that's failing. One of the problems that flaps can run into is if the venous drainage isn't very good, you could have blood coming in and it doesn't go anywhere, so then it pools and things get really swollen. And what the leeches do is just what you think they would do, is suck blood away. They actually have two functions. One is they could actually suck blood out of a flap and keep it from being congested. And also, leeches themselves make something called hirudin, which is actually a blood thinner. So it's thought that having a blood thinner there may also help reduce any clotting of the small vessels that may be occurring and contributing to that congestion. So do I use them? Fortunately, I don't need to, but sometimes when we need that, we do use them. They do have a very important and significant role in salvaging flaps that are struggling. Thank you.
That was wonderful. It was perfect.